So here we go. The last drug we spoke about yesterday, if I'm not mistaken, was hydralazine. So for today we are going to speak about hypertensive emergency. Can someone tell me please, what is the difference between an emergency and an urgency? Okay, yes, the end organ damage, exactly. So the end organ damage is existing in case of emergency. In urgency, no end organ damage. Also, one more tip, in case of emergency, that's a step 2 type of thing, but the treatment is IV and you keep the patient in the hospital. In case of urgency, the treatment is oral and you send him home. Keep in mind that the treatment include labetalol. Be careful, it's an ALOL, so that means that it is different. It works on both alpha receptor and beta receptor. And if you remember the clever card, which were calcium channel blockers, eclividibine and nicaradibine, clever card, and phenoldobam, and lastly nitrobroside. Keep in mind that nitrobroside, as I showed you yesterday, it had 5 cyanide molecules, but we are not allowed to reduce the... Yes, so if we speak... Okay, so if we speak about hypertensive emergency, guys, you need to be really careful. For example, you never, because someone asked about this is step 2 material, but you never give nitrobroside initially. Because why? What does nitrobroside do? Does it lead to vasoconstriction or dilatation? Leads to vasodilatation. If you have vasodilatation, what will happen to your heart rate? What will happen to the heart rate in vasodilatation? You will have, here is the thing, when your vessel increases in size, you will have a reflex tachycardia. So when the vessels become bigger, this is the heart, and this is the vessel coming out from the heart. When it's too big, the heart want to compensate for that decreased perfusion to the organs. So there is reflex tachycardia. When you decrease the size, you have vasoconstriction, there is a reflexive bradycardia. Okay, so in case of nitrobroside, there is a ridiculous amount of reflex tachycardia that can actually kill the patient. So what we do that we give the beta blocker first, and then we give the nitrobroside for the person who asked. But overall, guys, this is just a step 2 material, not step 1. In the step 1, you must only know how the drugs work and their side effects. Okay, so it's a short-acting vasodilator, arteries equals to vein. It increases cyclic GMB via direct release of the nitric oxide, can lead to cyanide poisoning. Taking a look at the cyclic GMB, you remember we saw this yesterday. Here is the nitric oxide, and where is our amigo? Here it is. Nitrates lead to direct release of nitric oxide, which lead to more cyclic GMB, which help you induce this enzyme, myosin light chain phosphatase, which lead to relaxation. Relaxation of the smooth muscles lead to vasodilatation or constriction. Dilatation. Good. Okay, so the next, we have phenoldobam. Phenoldobam is a dopamine D1 receptor agonist. It works in the coronary, peripheral, renal, splenic vasodilatation. Basically vasodilate all of your vessels. The main idea that it decreases the blood pressure and increases the natriuresis from your kidney because you have more perfusion to the kidney. Also, you can use it post-operatively as an antihypertensive medication. It also can lead to hypotension and tachycardia. Why tachycardia? It's a reflex tachycardia because of the vasodilatation. Okay, let's speak about nitrates. Do nitrates work more on the arteries or on the veins? Veins, exactly. It works more on the veins. Okay, good. So the stuff that you need to know about nitrates, that in the beginning speaking about nitrates, we have multiple types. We have something called nitroprusside. So for nitroprusside, it works everywhere, by the way, as the person said. But the general theme that nitrates mostly work on the veins. Nitroglycerin tends to be sublingual medication. Sublingual, it means you put it under the tongue. Lingua in Latin means tongue. That's why when you say someone is bilingual, it means that he speaks two tongues, which means two languages. Okay, so isosorbide dinitrate, which is like the drug that you use for prolonged period of time, and the isosorbide mononitrate as well for a long period of time. So mechanism, it vasodilates by increasing the nitric oxide in the vascular smooth muscles. We just spoke about the cyclic GMP and smooth muscle relaxation leading to dilatation in veins more than artery. Guys, when you dilate the veins, you will have less preload or more preload. Think logically. Yes, because when you vasodilate, there will be pooling of the blood inside of the veins. Thus, you will have less preload going to the heart. Is it a good thing or a bad thing? Exactly. In case, I love the answer, depends. That's true. Because sometimes you don't want to decrease the preload. But if the patient is suffering from, let's say, an MI, left side MI, if it was a left side MI, it's good because it decreases the O2 demand. But if we speak about a different condition, such as condition of right heart failure, it's a really bad idea because the patient already has a decreased preload. And if you decrease the preload even more, you kill him. Okay, clinical use, you can use it for angina, acute coronary syndrome, and pulmonary edema. So keep in mind that in case of why they do not write MI. Sometimes we use it in MI, but it can be really bad. Why? Guys, do you remember the Steele syndrome? The Steele syndrome, coronary Steele syndrome. Why nitrate sometimes can be really bad idea for someone with with an MI, because it can lead to the Steele syndrome, which is basically a vasodilatation distal to the area of obstruction. Yeah, I hope you remember what is coronary Steele syndrome. Okay, so just a sec. Yeah, here it is. If you remember, in coronary Steele syndrome, when you use a vasodilator, you can exacerbate the pain. Yes? Because you are enlarging a vessel that should not be enlarged. Okay, so moving back to nitrates. Okay, so here we have the following. So they write adverse effect, reflex tachycardia treated with beta blockers, hypotension, flushing, and headache. Why headache? Because of the vasodilatation, basically. Monday disease. What does it mean, Monday disease? So Monday disease, why pulmonary edema? Why pulmonary edema is something that we are going to speak a lot in when we discuss the pulmonology, but to give you a quick idea about it, it leads to relaxation of the vessels inside of the lung, which allows for more perfusion and more movement of the blood, and thus it helps clear the fluid from the lung much more faster, which decreases the amount of the edema inside of your lung. Also, it decreases the amount of the preload to the lung, which decreases the hydrostatic pressure inside of the vessels of the lung because of the pooling of the blood inside of the veins. So two mechanisms. One is direct on the smooth muscles of the lung, like the vessels of the lung, and the second one by decreasing the preload from the lung. Both of these help in the pulmonary edema because they reduce the amount of the fluid going to the lung. We'll speak about this in pulmonology. Okay, so speaking about reflex tachycardia, it's treated with beta blockers, and That's why we like to give actually beta blockers before the nitrates. Hypotension as well can be really bad, and it's a complete contraindication actually to it. Flushing and headache. You're like, why flushing? Because it leads to venodilatation. So basically you can imagine that the vessels will be dilated, so they will be able to get more heat outside. So headache, Monday disease. This is important, guys. Why? What is this Monday disease? So I know this just because I'm a doctor. So in ammunition factory and in a different weaponry factory, they used substances that contains nitrates. These substances, they basically make gunpowders from them, okay? And they contain nitrate. So you're like, okay, what is the big of a deal? The workers who work in these factories, all the week, they are exposed to nitrates. So what is happening in their coronary artery? Vasodilatation or constriction? Minor vasodilatation, but that's not the important thing. The important thing that in their head, there is also vasodilatation. Okay, so what is the thing? Well, why it's important? Well, here's the thing. Every single day, no, not that bad of a dilatation, does not lead to aneurysm, but every single day they are exposed to this freaking nitrates. And they have vasodilatation, dilatation. For the first couple of days, it's bad, you know? But then they are good with it. They don't really care. They feel good about it. Why? They feel good about it after the first couple of days. Let's say on Monday they come to work and they are exposed to the nitrates. They have horrible headache. They are like, oh, my headache, it's bad. On a Tuesday, Wednesday, Thursday, Friday, they feel good. So they feel good on these days. Why? Because they have tolerated this drug, okay? So Saturday and Sunday, they are losing that tolerance that they gained from this drug, okay? So when they come back on Monday, they are refreshed. Their body is fresh. Why? Because nitrate has a really short half-life. It goes out from the body really quick. So when they come back on Monday, again, the same horrible headache. Why? Because they were exposed to nitrates again. So they write here the following. Monday disease. In industrial exposure, I told you, battery factory, ammunition factory, and the stuff that makes weapons. Development of tolerance for vasodilating action during the work week and loss of tolerance over the weekend. So it can lead to tachycardia, dizziness, headache upon re-exposure, which is on Monday, and there is a complete contraindication with nitrates. Guys, be really careful about this contraindication for real life. Okay? So, exactly. So, contraindicated in case of right ventricular infarction. Which leads are having the ST segment elevation in case of right ventricular infarction. Which ECG leads have signs of MI in case of right ventricular failure. It's exactly, it's lead 2, 3 and AVF. So for the special leads, these are for the posterior wall. The posterior wall have special leads which we call like V7, 8 and 9. They are not required from you. But this wall, take a look at the posterior wall, but you don't have to know about this for step 1. This is step 2 type of material. Okay, contraindicated in the right ventricular infarction, hypertrophic cardiomyopathy as well. Why? Why hypertrophic cardiomyopathy? Nitrate is a bad idea. In case of using nitrate, do you have more blood or less blood inside of your heart? Yeah, less blood. And do you remember what happens to the severity of the murmur in case of Hypertrophic cardiomyopathy if you have less blood. Yep, increase, it becomes really bad. Exactly. So that's why it's contraindicated to have HOCM and nitrates together. Okay, concurrent phosphodiesterase inhibitor use. Well, you must know that there is this drug sildenafil, also known as Viagra, which is a drug used for erectile dysfunction. The main idea of sildenafil or Viagra is an inhibition of phosphodiesterase 5. Inhibition of the phosphodiesterase 5 increases your cyclic GMB. Increase in the cyclic GMB need to stimulation of the MLC phosphatase, which is the myosin light chain phosphatase, which lead to relaxation, vasodilatation, and that helps in the erectile dysfunction. Well, you are like, okay, so what is the problem of giving nitrate with it? Notice here that nitrate is here, so you have more nitric oxide and more cyclic GMB, so there will be a massive vasodilatation that can lead to brady or tachycardia. Tachy, remember, vasodilatation lead to a tachy. Okay, massive tachycardia, massive hypotension. Basically, you get yourself in a distributive form of shock and bye-bye, the patient dies. Okay, let's speak about the next point. So that was everything about nitrates. Just be careful of that old man who wants to get sildenafil from you and he is suffering from erectile dysfunction. There is other forms of treatment you can provide this guy from, but do not give him phosphodiesterase inhibitors. Okay, next. So, by the way, if you get a question about a man who's suffering from erectile dysfunction, look in the answers. The first thing you must know is to rule out other causes. If there is an option telling you to check the patient's psychological stuff, it's that one. And also, if the patient has morning erections, that means that his problem is psychological, not physiological. So keep an eye for morning erections. If he does have morning erections, it means that it's totally like psychological. For example, if he's fighting often with his wife, his parasympathetic is not working, so he cannot erect. Okay? Because erection is mediated by the parasympathetic. Ejaculation is mediated by the sympathetic. So if the man is really stressed in his life, he will still have the morning erections, but he cannot function during actual sexual intercourse because he can never become with his wife. And thus, just on the exam, when you see absence of morning erections, directly think, okay, could be an actual like pathological problem. But if it is existing, this morning erection, it is totally psychological. And the things you must do: first, check the psychological problems. 2, and it's the most important, check his medication. A lot of medication can cause that, like beta blockers. So anti-anginal therapy. The goal is the reduction of myocardial O2 consumption by decreasing one or more of the determinants of MVOs, which is the myocardial O2 consumption. So what controls our O2 consumption of our heart? The first one is the end diastolic volume. The more your end diastolic volume, the more or the less the O2 consumption. Tell me. If I have a lot of blood inside of my heart, well, yes, exactly, it's more. So if I have more blood inside of my heart, I should work more to eject that blood out. So basically, yes, increased preload will lead to the heart having to work more, leading to more O2 demand. Okay, so also blood pressure, when the afterload is huge, you must work extra time to kick it out. Heart rate, fast heart rate, consume more O2. Contractility, harder contractility, lead to more O2 consumption. So the next thing here, we see the nitrates. So the nitrates, end diastolic volume, what will happen to it? The preload, basically, end diastolic volume is like telling you preload. It will decrease because of the pooling of the blood, as we said. Blood pressure goes down, contractility. Well, if you have vasodilatation, what happens to you, tachy or a bradycardia? Tachy. So the tachy lead to increased heart rate, and there will be more contractility. Basically, you have upregulation of the beta receptors. Okay, ejection time will be reduced. Why? Because the contractility is higher. And the MVO consumption will be lower. Why? Because less preload and less work of the heart. So let's take a look at beta blockers. So notice here, guys, some stuff here are perfect for someone with a problem in his heart, like an MI. What is MVO? MVO is the amount of the demand of the heart for O2. Okay, so the demand of the heart of O2. So nitrate reduce the demand of the heart of O2, or the myocardial O2 consumption. Okay, so if we speak about the nitrate, now tell me, good or bad? Is this good or bad? The first one. Is this good or bad? Is this good or bad? Bad. This one is bad. Why? Because there is more consumption of oxygen. Is this one good or bad? It's bad as well. Yeah, more heart rate, more O2 consumption. Okay, so ejection time is reduced, that's good, and MVO is reduced, that's good. Okay, now speaking about beta blocker, end diastolic volume, no effect or a little bit increased. That's bad. Well, we don't want it to be increased. A blood pressure is low, that's perfect. Contractility is low, awesome. Heart rate is low, amazing. Ejection time is higher, that's bad. We don't want that. Okay, so beta blockers are overall reduce the MVO consumption. So these guys have good stuff, and these guys have good stuff. Like, if you notice here, guys, if we want to say what is good, what is bad, this was good, well, this was good, and this was good, and this was good. But these two were bad. But here, this is good, this is good, this is good as well, and this is good. So if you can appreciate this, if you can give these two drugs together, it will be awesome. Why? Because we get all of the good stuff together. It's like, you know, this really funny, a quick story that is funny. Marilyn Monroe and Albert Einstein. Marilyn Monroe came to Albert Einstein and told him, let's get married. We will get children that are really smart like you and really beautiful like me. And he told her, well, I think it's a bad idea, because if we get children, they might be, well, really ugly like me and really stupid like you. Okay, so we have this nitrates and beta blockers. So nitrates and beta blockers. If we give them together, the end diastolic volume, there will be no effect, it will be going down a little bit. If we speak about the blood pressure will go down, obviously. Why? The sum of the two effects. The contractility will be little or no effect because of the sum of two effects. The heart rate, the same deal. The ejection fraction, the same deal. But overall, MVO2, which is the amount of consumption of the O2, will go down significantly, and that's what we want. Veramabile is similar to beta blocker in effects, and but there is one thing that you must know, guys, regarding these drugs. Veramabile we like to use in an asthmatic patient. Okay, so why? Because beta blocker lead to bronchoconstriction, which is bad for the patient. So we have a drugs called bendalol and acetolol. They are a partial beta agonist that should be used with caution in angina. So you need to be really careful with using a partial agonist. What is a partial agonist? Well, a partial agonist is a drug that when you use it with a full agonist, it acts as an antagonist. You're like, what the? Just let me tell you again. So if I draw this for you in blue and tell you that this is a full agonist, okay? And in graph number, this is graph number 1, and I'm giving a full agonist. And in the green, this is a partial agonist, okay? So a partial agonist, if you give it alone, it acts like an agonist. But if you give it with an actual complete agonist, it acts as an antagonist, as you can see. Of course, here is the efficacy. So partial agonist alone, full effect. Vmax can be reached. We'll study this in pharma. But partial agonist with a full agonist, you cannot reach Vmax. Okay, let's go down there. We have something called ranolazine. Ranolazine. Oh, it's about the funny stuff. Let's see. It inhibits the late phase of inward sodium current, thereby reducing the diastolic wall tension and O2 consumption. What is this? Let's take a look at it. Come on, come on, come on. Okay, so if you remember, we had the typical and the typical cardiomyocyte, and there was movement of different electrolyte in and out. Oh, cannot see it here. Come on. No, they don't show a good picture here. I have to show it to you online. There is a picture that shows exactly where it works, but I had it in my first aid, but I lost it. I don't know why. Just a second. So the ranolazine is actually now, it's considered one of the newer drugs, agents, and thus they are using it much more often. It acts at something called the late current. Yes, okay, here it is. Okay guys, so here you go. As you can see here, what do you have here? You have this action potential, and this one down here is for what? This one is for the pacemaker cells, and the upper one is for what? It's for the typical cardiomyocyte. Look what it leads to. It leads to a weird shape here. You're like, wow, this acting the late phase and it's looking weird. Exactly. So that seems like why would you do that type of thing? Well, why I would do that is because it reduces the heart rate, basically. It prolongs the heart rate. So it inhibits the late phase of inward sodium current, thereby reducing the diastolic wall tension and O2 consumption. It does not oh, shoot. Okay, I made a mistake. Just a sec. Okay. So yeah. Okay, got it. So here it goes something like this. If you remember when we spoke about the typical cardiomyocyte, it had this late phase. So remember we had the plateau and we had the phase 3. We had sodium channels acting here. And the sodium channels are the ones inhibited in case of the ranolazine. That leads to multiple things. First of all, the plateau, it used to be, oh, let me ask you this. When did the heart contract in case of the typical cardiomyocyte? Which phase? Okay, good. So if the ranolazine inhibits that, like ranolazine works there, as you can see. So that will lead to like border contraction type of thing. So that will reduce the O2 consumption or increase the O2 consumption. Exactly, reduce. So it's angina refractory to other medical therapies. It's a really new drug, guys. And its adverse effects include constipation, dizziness, headache, and nausea. Constipation they like. Other ones are not important. Okay, sacubitril. I hope you remember this drug. We spoke about it before, but now we are going to speak about it again. First of all, let me re-explain what I said about this and then read what they write in first aid. Before reading this, yes, correct. It prolongs the plateau, the ranolazine. But if you take a look at about this, the A and B, if you remember, it was secreted from where? From the atria of the heart. And it's secreted upon which form of stimulation? Stretch, exactly. A and B, B and B gets secreted I ask like in which form of stimulation lead to hypersecretion of A and B and B and B. The answer was a stretch. Like in cases of hypervolemia, there will be stretch, secrete the A and B and B and B. Remember that there is an enzyme called naproxeline. Here is naproxeline. Naproxeline inhibits it. Remember that A and B and B and B are like perfect hormones. Why? They vasodilate and lead to diuresis, which is good for you. They decrease blood pressure, decreases aldosterone level, decreases fibrosis, and decreases remodeling. All of these things are good. And naproxeline is destroying them. So if you can stop naproxeline from working, that sounds like just perfect. So do we have a drug that inhibits naproxeline? The answer is yes. It's called sacubitril. But the problem is that when you inhibit naproxeline, you increase the A and B and B and B, which is good. But in the same time, you decrease the degradation of angiotensin 2. Angiotensin 2 is the villain. He's evil. And he can lead to vasoconstriction of fluid retention, which really bad in case of heart failure, for example. Angiotensin 2 also increases your aldosterone level, increases your fibrosis and remodeling. So do you want more angiotensin 2 or less angiotensin 2 in your body? Yeah, you want less, for sure you want less. So what do? That we give combination therapy. In the same tablet, you will have sacubitril, which increases your A and B basically, and you have valsartan, which prevents the activity of angiotensin 2. So let's take a look what they write. A naproxeline inhibitor that prevents degradation of natriuretic peptide, as you can see here. Angiotensin 2, as you can see here, and substance P, which leads to vasodilatation, which decreases the extracellular volume. Okay, so clinical usage. So it's used in combination with valsartan, as you can see down there, to treat heart failure with reserved ejection fraction. So with reduced ejection fraction. So we have the P is for preserved and the R for reduced. So if you see here, the letter P, it means preserved. Letter R, it means reduced. What is the normal ejection fraction, guys? Yes, excellent. Good. So an adverse effect, hypotension, hyperkalemia. You are like, wait a second, why hyperkalemia? It does not make sense. Why would this drug lead to hyperkalemia? Well, here is the thing. If you give him alone, not with anything else. If you give him alone without the valsartan, what will happen to the level of angiotensin 2? It will increase. Look, the naproxeline, what it leads to, it degrades the angiotensin 2. So if you give sacubitril, it will inhibit, I said alone. If sacubitril is given alone, it will inhibit naproxeline. Naproxeline inhibition will prevent degradation of angiotensin 2. You will have more angiotensin 2. Also, it will prevent the making of A and B and B and B. Okay? It will prevent the degradation of A and B and B and B. So, if you have more angiotensin 2, what will happen to the level of aldosterone? Increases. So, when it increases, what will happen to... let's see. Yes. So, if you have... Yes, exactly. So if you have, oh, I see what they did here. They have a mistake, a typo, I guess. Look, guys, they here mention one drug, sacubitril. Yeah? If that was used alone, you will have more what? Angiotensin 2. More angiotensin 2 will give you more aldosterone. If you have more aldosterone, what will happen to your potassium level? It will decrease. No. Your potassium, hyperaldosteronism lead to hypokalemia because there will be excessive excretion of the potassium. So this hyperkalemia thing, be careful of it because it is, it increases sodium absorption, that's different. So hyperkalemia will happen if you give it in a combination with valsartan. So the side effects they are mentioning here, it's when it's given in a combination with valsartan, because the hyperkalemia occurs in valsartan for sure. So it's contraindicated with ACE inhibitor due to the risk of angioedema. Angioedema I will show you in the future. Okay, now we'll speak about different categories of a drug. So the next category of a drug is a form of drugs that you will be using every single day in your practice. Literally, lipid lowering agent. So, exactly, you never give it alone. It's a bad idea. So, lipid lowering agent, we have so many of them. Sadly, for the step 1, you must memorize all of them. You must know all of them. For the step 2, you will discover that you only need to know 2 of them, and that's it. But for the step 1, you must know every single one of them, what it reduces mainly, and all of that stuff. But if I were in your place, there is high yield ones and less high yield ones. So to start with, before speaking about this thing, you must understand this graph. So you're like, ooh, this is cool. Before understanding this graph, you must understand the graph in biochemistry. You're like, okay, let's take a look. Just a second. There is a graph in biochem that has the lipid metabolism. Here it is. So you're like, wow, what is this? Well, I know. So you must know this. I will not go through it now because I will explain it when we do biochem, but I'm just going to give you general ideas. So the general ideas go something like this. Inside, when you eat a piece of fat, okay, what happens to it? It enters your intestine. It will go and get degraded by some lipases at the brush borders of the intestine. Then it will be absorbed. And after it gets absorbed inside of your intestine, you must know this. It will go to your lymphatics, okay? That's why lymph looks white. And then it goes to your thoracic duct. Thoracic duct, must know exactly where it clears. It goes to your left subclavian vein, not the right one. The left subclavian vein. After that, it goes to your systemic circulation, obviously. Blah, 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 blah. Long story short, in the end, you have formation of what? LDL like to go from where to where? From the liver to the peripheral tissue. HDL like to go from the peripheral tissue to the liver. Well, you want more lipid in the peripheral tissue or less lipid in the peripheral tissue? More cholesterol in the peripheral? Less, yes. Why? Because more cholesterol in the peripheral tissue precipitate to which disease? Atherosclerosis. Excellent. Okay, let's take a look on the right. So as you can see here, we have the intestinal lumen, and then we have absorption of what? Cholesterol, free fatty acid, and bile acids. And all of them goes inside of your enterocytes. Inside of the enterocytes, there is something here called chylomicrons. Okay, guys? So the chylomicrons, it travels inside of the thoracic duct and then enters your left subclavian and all the way until they reach the blood. Chylomicrons are basically like big cars containing a lot of cholesterols inside of them, different forms of cholesterol. So they have inside of these chylomicrons, you have LBL affecting it. And this LBL, lipoprotein lipase, basically, when it affects it, it will lead to creation of a free fatty acid. Well, this is not bad. At least it's working. It's degrading something. Also, it can create what? HDL pool. Well, is HDL good or bad for us? It's good. Why it's good? Notice here, guys. It's taking HDL is still a cholesterol, but it's taking the cholesterol from the periphery to the liver. You are like, wait a second, that does not sound good. You are taking cholesterol to the liver. You want to make my liver fatty? Well, it's true. It takes fat to the liver, but at least liver know how to deal with fat. Your tissue do not. Okay? Your liver can deal with it. Exactly. Your liver can deal with the HDL, but if we speak about our peripheral vessels, for them, cholesterol is really, really bad idea. So the HDL goes and bind to the liver and get consumed by the liver, and many stuff happen there that I will tell you in a moment. But what is important here? Okay, HDL is inside of our body, and that's good. Also, we had absorption of different forms of cholesterol. So HDL goes inside, we have a creation of the cholesterol inside of our body. There is a freaking pathway here that, like, when the students see, they become scared. Do not get scared. I will show you it in biochem, so you will not be as scared of it. Just a second, here it is. Yep. So basically, I will not go in details, but to make fatty acids, you need citrate, which you get from the TCA cycle, and you make then acetyl-CoA, malonyl-CoA, and then fatty acids, okay? And to burn that fatty acids, you must know the burn house of the cell. The burn house of the cell is the mitochondria, okay? So you bring the free fatty acids and you throw them inside of the mitochondria, which is the burn house. And that creates you acetyl-CoA, which can be utilized by the TCA cycle. Just notice here what I said about this. I told you that the citrate, which comes from the TCA cycle, can make you fatty acids, okay? After going in a few steps like acetyl-CoA and malonyl-CoA. So backing to CVS. So you can notice here that same idea, acetyl-CoA become Hmg-Coa, which become a mevalonate, which eventually becomes cholesterol. You're like, okay, what is the big of a deal? Well, do we want more cholesterol in our body, or we do not want more cholesterol in our body? Well, actually, this question answer, it depends. Is cholesterol important for our life? Is cholesterol important for our body? Does it have a function? It does. For hormones, for example, excellent. 6 hormones. Without cholesterol, you will never have testosterone. You will never have estrogen or progesterone. You will never have cortisol. You will never have aldosterone. Okay, what else? Except hormones. Why is like cholesterol super important? Cell membrane, exactly. It's located in the cell membrane. And without him, you cannot maintain normal integrity of the cell membrane, okay? And that's a really bad idea. You want to maintain normal integrity of the cell membrane. So cholesterol is actually good for us, but the quantity is the problem. You want it, but you don't want too much of it, okay? So the Hmg-Coa Reductase, it converts Hmg-Coa to mevalonate. Guys, every single one of you in his life will get at least, I don't know, 20 questions on this. Hmg-Coa Reductase. Know it, memorize it, do whatever you want with it. So we have different types of Hmg-Coa Reductase inhibitors, which are, what is the main function? You are preventing the creation of cholesterol, okay? So yeah, it's a rate limiting enzyme, so you must know about it. Okay, so it's decreasing the making of cholesterol. That seems good if it is inhibited. So let's keep that for a moment and just let's speak about cholesterol. Okay, we got cholesterol. Cholesterol can be converted to VLDL. Is VLDL good or bad? It's bad, yeah. Triglyceride also can be converted in VLDL. So VLDL goes to your periphery. He's bad, but you know who is worse? His son, LDL. Well, is LDL bad? Yeah, he's the worst. Yep, he can deposit into your peripheral vessels leading to atherosclerosis, which is horrible. Also, we have something called lipoprotein lipase. This guy is actually good. He can kill VLDL and get you free fatty acids from it. But when he does that, look what happens. LDL, that sucks. Well, LDL can be reabsorbed by which lovely organs that we have that prevent us from getting atherosclerosis? Liver. Yes, by the LDL receptor located in the liver, which sends this LDL receptor, they sense what? They sense the LDL and they absorb it and make more cholesterol out of it inside of the liver, which can lead to fatty liver, but screw that for now. So free fatty acids can accumulate and can form adipose tissue. And the adipose tissue keeps accumulating until you have a belly and all the ladies run away from you. So yeah, be careful of that LBL. So, and adipose tissue can undergo the process of lipolysis, which can lead to free fatty acids making. Okay guys, I'm going to give you names of hormones and you will tell me if the process of lipolysis will be more or lower. Insulin, will it increases the lipolysis or it will decrease the lipolysis? Okay, it will decrease the lipolysis, yes, because it basically like it's an anabolic form of hormone. It will hide the sugar inside of the cells. Okay, one more thing. If I speak about the glycogen, yeah, glycogen. No, sorry, glucagon, what I'm saying, glucagon. Opposite, exactly. So let's speak about the following. Now we are going to speak about the drugs. So enough playing, now let's go to speak about the drugs. So cholesterol. There's a drug called Azitamibi that inhibits the absorption of cholesterol. Please do not make the mistake of thinking that it's the same as bile acid reabsorption inhibitors like the Resins. These are totally different, okay? So if I use one of these drugs, where this cholesterol will go? It will go into your boob. So you can imagine if you have a lot of fat in your boob, will it float? Yeah, it will float, fat float. If you don't believe me, go to the kitchen, bring some oil, put it on water, it will float upward. The same thing with cholesterol, since it's a fat, it will float. Okay, so cholesterol, if you prevent absorption, it will lead to azitamibi. Due to azitamibi, obviously it will lead to bloating, you know. Patient will be bloated, he will be like, oh, I feel bad. And yeah, but that's not the bad thing. The bad thing that we have a few vitamins that are fat soluble. Do you know which vitamins are fat soluble, guys? Not the B vitamins, no. The vitamins are with the mnemonic ADDICT, okay? ADDICT, which is A, D, E, and K. Just remember, an addict, okay? Without the T. So, so you can imagine that all of these basically vitamins will go to the feces, so you can have a problem with vision, problem with bones, anemia, problem with coagulability. So it's really serious actually. So what the resins prevent the bile acid from working, so that also can lead to fatty stools, like when you use cholestyramine and cholestyramine and cholecivlam. Weird names. But guys, I'm going to tell you now about a question that I saw the other day. So there is a drug called leflunomide, which is used for cases of arthritis, okay, rheumatoid arthritis. So they mentioned the patient who's taking leflunomide, and then they started to give him what? Cholestyramine. They tell you that since he was started in the cholestyramine, the leflunomide was not functioning anymore. Initially, I did not understand the question. I have to say, I was like thinking, okay, why leflunomide is related to it? Eventually, I saw that leflunomide is actually a fat soluble. So the correct answer was that there is a decrease in the enterohepatic circulation. So decrease in the enterohepatic circulation. What does that mean? It's the movement from the entero to the hepatic, from the intestine to the liver. So, okay. Okay, so we spoke about the resins, we spoke about the cholesterol absorption inhibitor. What else do we have? So I kept telling you how lipoprotein lipase is a good guy and how it create us free fatty acids from the chylomicrons, which are full with the triglyceride, and it makes us free fatty acid from VLDL, which is also full with the triglyceride. So there is a drug that leads to upregulation of this LBL, which basically lead to a huge decrease in the triglyceride. Okay, why? Because chylomicrons are full with the triglyceride. This guy is working here. VLDL, it basically comes from triglyceride. This guy is working on them here. So these are the fibrate, including gamifibrazole. I can repeat, of course. So if we speak about chylomicrons, what are these? Chylomicrons are just like cars, and inside of these cars there is a lot of what? Triglyceride, cholesterol, different substances. Oh, the leflunomide question you mean? Okay. So they give a question about leflunomide. The patient had rheumatoid arthritis. This is a real exam question, by the way. The patient had rheumatoid arthritis. They give him leflunomide, which is a drug that decreases your pain, basically. Okay, so it was working perfectly. Then the patient was started in cholestyramine, and they tell you that the drug stopped working anymore. It stopped working, and the patients begin to feel pain again. And they ask you why. The answer is due to decreased enterohepatic circulation. Enterohepatic circulation is the ability to reabsorb bile acids inside of your intestine. You are like, how is this related to leflunomide? Leflunomide is a fat-soluble drug, which means it needs fat to dissolve into and get absorbed with. If the fat is not being absorbed, the leflunomide will not be absorbed as well. The process of absorbing a fat, sending it inside to the circulation and eventually to the liver, we call it enterohepatic circulation. So if your enterohepatic circulation is messed up, your leflunomide cannot be absorbed, and that will lead to pain in the patient. I hope it makes sense. So we have the following fibrates. Welcome. We have the following fibrates, and all of these inhibit the LBL, which is lipoprotein lipase. So chylomicrons have a lot of triglyceride inside of them. So you wanna do what? You wanna increase their degradation. Also, the VLDL have a lot of triglyceride inside of them, so you wanna increase their degradation with the LBL. Okay, now you have a free fatty acids, and we have adipose tissue that can lead to lipolysis and free fatty acids. Well, free fatty acids is much better than triglyceride, but they are not perfect. They are still bad, you know? So a drug called niacin, which is also a vitamin. Can someone tell me which vitamin it is? B3. And can someone tell me it's B3 and it can lead to flushing, and the flushing, is it mediated by histamine or prostaglandins? Tell me, please. It's prostaglandins. You must know this, guys. You must know this. If you forget about it, just remember. You prevent the flushing in case of niacin by giving what? NSAIDs, okay? So the flushing is mediated by prostaglandins. Okay. So let's take a look at this area. At this area, we saw that okay. So by secreting more bile acid, which are made up of lipids, consequence you that make more lipid from the periphery to the bile. Not sure I understand that. So acetyl-CoA, we have Hmg-Coa, and that creates us mevalonate. So we have this enzyme is working here. So imagine this, guys. If you inhibit this one, you will have less cholesterol. Okay? So if you have less cholesterol, done. You are in a good shape. So that's why the most commonly used drugs are the following. Okay? The statins. By the way, you must know about these two drugs. These two drugs tend to be more functional than the other ones, okay? And the rosuvastatin. I'm sorry, not simvastatin. The atorvastatin and the rosuvastatin. These two drugs are amazing, okay? The other one tend to be a little bit shitty. There is something you must know about bravastatin. Bravastatin does not work on the cytochrome B450. Make a note about this, please. Okay. So bravastatin does not work in the cytochrome B450. Atorvastatin and rosuvastatin are one of the most potent drugs. So you can see here the LDL receptor which consume the what? The LDL and they bring it back to the liver. So there is something called the BCSK9. So this BCSK9 is basically lead to formation of more LDL receptor. And there is we have the following. We have this monoclonal antibody that prevents receptor degradation. Is it good that we are preventing degradation of the receptor? Why? We are trying to prevent the degradation of the receptor. So we will have more receptor. Is having more receptor a good thing? Yeah, why? Because we consume all of the LDL from the periphery. We get it back to the liver. Yeah? Less LDL in the periphery, more LDL in the liver. Perfecto, liver can deal with these guys, but your periphery cannot. So this monoclonal antibody prevent the degradation. That's their function. Prevent the degradation of that guy, basically. And thus, you will have more absorption of the LDL from the periphery, and it goes back to your liver, which he can deal with, actually. So, these drugs include alirocumab and ovolocumab. I really could not remember the names. I just remembered like a comb, you know, like this guy, the one you do your hair with, comb your hair. Okay, comb. So let's continue. Let me just take a look at the time. Okay, so that was just an overview about the lipid lowering agent. This will be much quicker. So now let's take just 10 minutes break, refresh yourself, move your legs, and come back. You can make the sound of a fish. A rabbit. Rabbit can speak. Read that and ask him. Can rabbit speak? I know he can scream, but he cannot speak.
I don't recommend you know this.
Okay guys, welcome back. Let's continue. Just a sec. Let me check one thing. Yes. Okay. So let's see. Now we are going to speak about the drugs themselves. So starting with the first family of the lipid lowering drugs. We have the Hmg-Coa Reductase inhibitors like atorvastatin and simvastatin. Simvastatin is one of the oldest drug out there. Also lovastatin. They are really old and almost not used anymore. Now we'd like to use atorvastatin and rosuvastatin. As you can see, they mainly decrease the cholesterol, which make them decrease what? LDL significantly, which is a really good thing because that's what we want. They also do decrease the triglyceride, but if they ask you about what is the best drug to decrease the triglyceride, the answer is fibrate, okay? Answer is fibrate. While which one is the best to decrease LDL, and this is relatively cheap, is the Hmg-Coa Reductase Inhibitor. Okay guys? So the Hmg-Coa Reductase Inhibitor decrease the LDL, decrease the triglyceride, and the mechanism of action is the inhibition of conversion of the Hmg-Coa reductase. and it prevents the conversion of Hmg to mevalonate, which is a precursor of cholesterol, as you can see here on the right. Yeah, so just to prevent a step. So there will be more LDL recycling, which is good, and it decreases the mortality in coronary artery diseases patient. If you remember the monobash mnemonic I told you about, I told you that the monobash, the S stood for what? It stood for a statin. You always give a statin. Okay, so the next thing you must know is regarding the side effects of this drug. They are highly hepatotoxic, but they are not the only one. Most lipid-lowering drugs are hepatotoxic because they work in the liver. They also can lead to myopathy. This is what your step 1 question would be about. The myopathy, especially when used with fibrate or niacin, because these lead to similar myopathy. So let's speak about the myopathy for a little bit. I will take a couple of moments speaking about it. First of all, it's affecting the striated muscles. Guys, which muscles inside of your body is considered a striated muscle? Yes, skeletal muscle and cardiac muscle. Okay, so these striated muscles, we have the muscle cell. Here it is, beautiful muscle cell. And it contains like one substance that will be inhibiting the wall. And after that happens, there will be creation of pores and destruction of the cell. We call that a process rhabdomyolysis, okay? Rhabdomyolysis. When rhabdomyolysis occurs, there will be many substances released into the circulation. The most important of them is something called myoglobin. You are like, oh, you mean hemoglobin? No. This thing is called myoglobin, okay? So the difference of myoglobin from hemoglobin, how many oxygen can a hemoglobin handle? 4. But myoglobin can handle only 1. That's the difference between myoglobin and hemoglobin. Hemoglobin is 4, myoglobin is 1. Okay. How many iron molecule does hemoglobin have, and how many iron molecule does myoglobin have? It's also 4 and 1. Okay, so myoglobin, it's good for the kidney, yeah? No, it's not. Okay, excellent. Why? Because when it goes to the kidney, it can lead to acute tubular necrosis. You're like, acute tubular what? It's acute tubular necrosis. It's a pathology that we'll be speaking about this month. As you saw, according to our schedule, the next system will be renal. And yeah, I'm really excited about this system because it's both really important and it's spelled up on the CVS. So if you understand CVS good, renal will make you understand it even better. So it can lead to acute tubular necrosis, which basically lead to destruction of your proximal tubule cells, which is like the proximal most portion of the tubules of your kidney. Okay, so let's go back here. Rhabdomyolysis. What will happen to the potassium level if the cell is destroyed? Will there be more potassium in the circulation or less potassium in the circulation? More, because cells are basically bags of potassium, guys. There will be hyperkalemia. Is hyperkalemia good for our heart? No, it's really bad. It can precipitate to arrhythmias. Excellent. So you can see here the next thing that says about bile acid resins. And bile acid resins are those ones who prevented the absorption of bile acids. So they tell you that they decrease the LDL, which is good. So now you need to be really careful, guys. So they can slightly increase the triglyceride. They can slightly increase the triglyceride. Why this is even important? It's slightly, it's irrelevant. Well, it's important because they want to annoy the shit out of you on the test day to ask you about which one of the following increases the triglyceride. And when you first read first aid, you will never notice it. So I'm just putting a spotlight for you guys on it. Remember that bile acid resins slightly increase the triglyceride. Exactly, yes. The specific gravity of the urine in case of rhabdomyolysis will be significantly higher. And what makes it interesting, if you do the dipstick, urine dipstick, there is something called urine dipstick. And when you do this urine dipstick on this patient, you will see that it's positive, okay? And yeah, it's basically, you can check for multiple things, but if you check for blood, it will be positive. But when you do the microscopy, okay, when you do the microscopy, it will be negative. Because myoglobin is not an RBC, okay? So there will be no RBC in the urine. But when you do the dipstick, you will find the presence of what? Of blood. Why? Because the test here, it checks only for iron. And myoglobin do have iron in it. Okay, next. So bile acid resins, it prevents intestinal reabsorption of bile acid. Thus, liver must use cholesterol to make more of it. Yeah? So I cannot make bile acid. Well, where is bile acid made? It's made inside of your liver. And how it's made? Well, basically your liver consumes cholesterol to make bile acids, which then they will be combined with a little bit of bilirubin, and that will create you what? The acid, okay? The bile. And if you do not have this, you do not have bile acids, your liver must secrete you more cholesterol to make more. So you will lose more cholesterol. Sounds effective. But it has a lot of side effects, like GI upset, decreased absorption of other drugs and fat-soluble vitamins, which can be really serious, guys. Guys, do you remember, if I have hypovitaminosis, vitamin E, which is a fat-soluble, what is going to happen to me? Reduced vitamin E. Anemia, good. Also subacute combined degeneration, nervous system. Okay, the anemia will be microcytic or macrocytic? Microcytic, exactly, that's how we differentiate it. Okay, if we speak about Azitamibi, the Azitamibi goes something like this. It decreases the absorption from where? It decreases the absorption from the, as we said, from the cholesterol from the small intestine. So, if that is the case, there will be highly reduced amount of LDL, prevents cholesterol absorption at the small intestine brush border. And there will be an increase in LFTs like most of these drugs, and you can just think about it. Less cholesterol absorption from the intestine. Obviously there will be diarrhea. Okay, so the next, we have something, a drug called fibrate. So fibrate has the following. It has all of these drugs with the word fibro or fibra in the name, and they, what is LFTs? Liver function tests. Liver function tests. Okay, so fibrates, we have LDL will be reduced in them, HDL is slightly increased. But what is the most important thing in this page? The most important thing in this page is to appreciate that the triglyceride will be the most decreased in this case, which is triglyceride. They will reduce the triglyceride the most. How? By upregulating the LBL, which is the lipoprotein lipase we spoke about, which increases the triglyceride clearance. Okay, so seems like a cool guy. Yeah, it also, and you must notice this one, it activates the PPAR alpha to induce HDL synthesis. Why when I said alpha, I was super serious about it. Because guys, when we speak together about endocrinology, I will be telling you about PRPB gamma, which is one of these drugs that is called a TZD, glitazones, or TZDs we call them, okay? Thiazolidiones, As you can see, they activate the BBAR gamma, okay? While if we speak about a drug that is a fibrate, it's BBAR alpha. That's super different from each other. This is alpha, that one is gamma, okay? Know that these two exist. Do not get confused between them. They will put it in the answers for you. They will tell you about fibrate, and they tell you that it activates the BBAR alpha, and then they will mention it activates BBAR gamma. To keep them straight, remember, in the first state, CVS is before endocrinology, so alpha comes before gamma. Okay, so it activates the BBAR alpha to induce HDL synthesis. The adverse effect and the problems include myopathy, which increases the risk of statin, cholesterol gallstones, and via inhibition of the cholesterol 7-alpha hydroxylase. So that can lead to cholesterol stones, and I will explain for you exactly the mechanism when we reach GIT, which is super interesting actually how it happens. It's basically like the bile you make is made from bilirubin and from cholesterol, and if you have hypersaturation of one of these two guys, you will get what? You will get a stone formation. Okay, so the next drug will be as follows. The next drug is niacin, which is vitamin. Which vitamin it is? B3. Excellent. So the B3 will reduce your LDL, increase your HDL, and decrease your triglyceride. It can lead to inhibition of lipolysis, hormone-sensitive lipase, in adipose tissue. It reduces hepatic VLDL, which is like just makes sense. Why it makes sense? If you take a look here, the niacin lead to less FFA, yeah, less free fatty acid. Less free fatty acids, less triglyceride eventually. Less triglyceride, less VLDL. Less VLDL, well, that leads to less what? Less VLDL. Done. Oh, less LDL, obviously. Yeah. But the main idea is that it decreases FFA, which decreases TCA, triglyceride, which reduces VLDL, which reduces LDL. Okay. So the problem is that you must memorize the pathway. That's the annoying thing. So as you can see here, the patient will have flushed faces, which can be decreased by NSAIDs, which means that it was mediated by prostaglandins. Also, patients with niacin, they can be complicated, and you must know these two: hyperglycemia and hyperuricemia. So never ever give them to a diabetic patient or in a patient who has gout. Okay, Bcsk inhibitors like alirocumab and evolocumab. Remember the cumab. They decrease the LDL significantly. How? By inactivating of the LDL receptor degradation. When I say that, it means I have more receptor or less receptor. I'm preventing the degradation. Do I have more receptor or less receptors? More receptors, yes. So inactivation of the LDL receptors degradation, which increases the removal of the LDL from the bloodstream. And this LDL receptor are located on which organ? We just saw it, guys. They are located on the liver. Here they are, okay? So remember, when it's inhibited, the patient will have, again, problem with the muscle. But what is the most important for you guys? What is the most important is the encephalopathy due to this monoclonal antibody. You must know about the encephalopathy. Okay. One more thing. Before moving on, I want you to know what does BBAR alpha, the one that we spoke about in fibrate, stands to. It's the peroxisome proliferator activating receptor alpha. Why I'm telling you this? Because they do ask about it. They do ask about the full name. So you must know the full name. Okay. So the last one is the fish oil and marine. Okay, yeah, you can so speaking about the fibrate. Fibrate activates the BBAR alpha, which induces BCK. BCSK. Okay, this one, the BCSK9. Yes. Okay, the BCSK9. Okay, let's speak about it then. So the BCSK9 inhibitors, what they are? So, guys, there is like these killers. Okay, and here we go. So we have something called Ldl receptors here. Okay. Okay. So I thought you are okay. You confused me, man. Okay, last one. The BBAR alpha, you must know which drug affects it. It's the fibrate, and when it's activated, that leads to making of more HDL. Okay? And when you have more HDL, that leads to lesser problems in your body, because like you can deal with the cholesterol much better. It gets bringing from the periphery to the liver. And speaking about the BBAR alpha, you must know what does it mean. I will repeat that as well. So you must know what it means, the BBAR alpha. The BBAR alpha means the following. It's an abbreviation for paroxysmal proliferator activated receptor alpha. Okay? You must know the full name. It's written paroxysmal proliferator activating receptor alpha. Okay? Someone can take a screenshot and just like put it there. So, speaking about the BCSK9 inhibitors, normally on our liver there is located what? We have a receptor, and this receptor is the LDL receptor, which normally sends the LDL and, well, basically endocytose it inside of the liver for degradation, which is a good thing. So we want more receptors, correct? We want more receptors. How can we have more receptors? Well, you can have hyperproliferation of them. Well, that's not possible. So what can we do instead? Well, you can prevent their destruction. How can I prevent their destruction? Preventing their destruction by inhibiting the molecules that can lead to downregulation of them, which is BCSK9. So we have monoclonal antibody that inhibits the BCSK9, thus we will not have degradation of the receptor. No degradation and destruction of the receptor, that means more receptor. More receptor, that's good thing, which means there will be more removal of the LDL from the bloodstream. Okay? You must know about two side effects, the myalgia and the encephalopathy. They ask about the encephalopathy. The fish oil and the marine omega-3 fatty acids, which is like in the fish. Notice here that the LDL actually will be slightly enlarged, okay? It will be slightly enlarged. And the HDL will also be slightly enlarged. But there will be a decrease with the triglyceride on large doses. Well, why would someone take it if that is the case? Well, people take it for other causes. A lot of people believe that essential oils can lead to decreased risk of cancer, which has not proved any clinical significance, but a lot of people believe in that. It's true that they make many enzymes located in our brain, and they are really important for it, and it's also important for hormones. But to say that they can prevent cancer, this is just too much. So there is no actual study that says that it prevents cancer. Yes, it can help in building the neurons, that's correct, but it cannot prevent cancer. There is no well-performed study that can prove for you that these can prevent cancer. But it's like a lot of people, especially those anti-vaxxers, speak about it. So you must know what is it as a doctor, because the anti-vax will come and ask you. So it's believed to decrease FFA delivery to the liver, which is the free fatty acids to the liver, and thus decrease the activating of the triglyceride synthesizing enzyme. Remember what I told you guys. I told you When you have less free fatty acids, you will have less making of triglyceride. As you can see here, like cholesterol decreases your VLDL, which is basically combined of cholesterol and triglyceride. Thus, you will have less VLDL in your body. So, if you go back here, you can see that it can lead to nausea and fish-like taste. Seriously. Okay, let's just take a quick look here. Cholesterol can be metabolized by the following. It can become bile salt, and or it can be excreted as cholesterol. And how it can become bile salts? Well, with using of the enzyme cholesterol 7-alpha hydroxylase. If you use fibrates, for example, fibrates lead to inhibition of cholesterol 7-alpha hydroxylase, which lead to shunting and movement of the pathway to the other side, which lead to a lot of cholesterol to be going where? Inside of the bile. That leads to supersaturation of cholesterol and formation of stones. That's why fibrates can lead to cholesterol stone. Not bilirubin stone, but cholesterol stone. Okay, 3 pages left. Okay guys, so we will take just 5 minutes break because this thing is just like cause headache, seriously, I know. So now we are going to speak about something a little bit more interesting and much more useful for you for your test. So let's take just 5 minutes break, be back and finish up with fun. Okay, guys, let's finish up cardiology. So the next thing we are going to speak about are the different forms of anti-arrhythmic drugs. If you remember, we had two forms of cells inside of our heart. We had the typical cardiomyocyte and the atypical cardiomyocyte. Oh, wait a sec. Before speaking about the antiarrhythmic, let's speak about digoxin. So, digoxin, well, you know it, guys, already. Can someone tell me which pump is inhibited? We spoke about it, if you remember, in the first class. Yeah, so it's the sodium potassium ATPase. That's correct. Okay, good. And when that is inhibited, there will be accumulation of which electrolyte inside? Calcium, yes. So as you can see, when you inhibit the sodium potassium ATPase, there will be, this is inhibited. So potassium will be stuck outside and sodium will be stuck inside. So when there is more sodium inside, the calcium sodium exchanger should not work, you know? So it will stop working. So there will be more calcium inside. And then you will have calcium-induced calcium released from the sarcoplasmatic reticulum. Let me ask you this, guys. See this little molecule they draw for you here? It's the molecule that normally get calcium from the outside of the sarcoplasmatic reticulum to the inside. So what is the name of this molecule that brings calcium from the outside to the inside? Phospholamine. Yeah, exactly. So someone is asking sodium out, potassium in. How the hell? I know that normally that potassium is more inside of the cell and sodium normally is outside of the cell. So what the hell are you speaking about, Iyad? It does not make sense. You are wrong. Well, man, just chill. Don't kill me. Look, it's an AT-base. AT-base means that it requires energy, okay? So it's pushing against the gradient, not with the gradient, okay? So basically it's against the gradient, not with the gradient, because it has an AT-base. Because you need to keep potassium inside. How can you keep potassium inside if you will not use an AT-base, okay? So exactly, that's how you maintain the membrane potential. So, okay, so more calcium lead to calcium-induced calcium release. You have more calcium. Eventually, you will have cardiac contraction because of the increased calcium. A really long process that we'll speak about when we discuss musculoskeletal because it's also there. So, more calcium, more positive anotropy. Anotropy, what does it mean? What does anotropy mean, guys? Yep, it's contractility of the heart means anotropy. Contractility of the heart. Yeah. Okay, so it stimulates vagus nerve, which decreases the heart rate as well. Okay. So the clinical use, it's used for heart failure, but you must know one thing, guys. It does not improve the mortality. It's just symptomatic. That's it. It's for the symptoms. It can be used in case of atrial defibrillation, but you must know why. Okay, so in heart failure, you need to know, okay, we use it because it increases the contractility. Notice here, we said that it stimulates the vagus, yeah? Which decreases the heart rate. Cool. So we use it in AFib. Why? Because of the stimulation of vagus that decreases the conduction at the AV node and depresses the SA node. Why? Because vagus is stimulated, yeah? Okay. So adverse effects include cholinergic effect. Cholinergic effect include, well, you know, dumbbells, diarrhea, and all of the other ones. So nausea, vomiting, diarrhea, blue-yellow vision. Think about the Van Gogh, arrhythmias, and AV block. Let me ask you something, guys. If I have a blurry, let's say a blue vision, what side effect of which drug? Blue vision. It's from a drug we spoke about today. I did not. Yep. Sildenafil. Yeah. It makes you get a blue vision. It's a blue pill that gives you blue vision. So yeah. Sildenafil. Amiodarone makes you blue, but I'm speaking that it makes you see blue coloration around you, basically. Okay? So, yellow vision, digoxin. Blue vision, that will be sildenafil. Okay, it can lead to hyperkalemia, which indicates poor prognosis. So if the patient has hyperkalemia, he will have poor prognosis because he can more easily be precipitated to the arrhythmias. Okay, so factors predisposing to the toxicity include what? Include the first of all, renal failure because of less excretion of what? Digoxin. So what? Well, digoxin is really famous for having really low therapeutic window. What is a therapeutic window? A therapeutic window is a window located between two margins. The first margin is the therapeutic dose. And the second margin is the toxic dose. And here on the y-axis, you will have what? How much is the dose? So let's imagine, just for example, like here it's 100 and here it's 200 or 150, 150 milligram. So the therapeutic dose of this drug will be the toxic dose minus the therapeutic dose, okay? For digoxin, it's really narrow. It's something like this. Yeah, and you need to stay in between. If you have poor clearance due to kidney failure and you give the same dose, the drug will go up here. It will become toxic, okay? So also in case of hypokalemia, permissive for digoxin binding at the potassium site on the sodium-potassium ATPase. So sodium-potassium ATPase, you must know where exactly the digoxin inhibit. It does not inhibit at the sodium site. It inhibits at the potassium site. Do not confuse the symptoms with this. What do I mean by that? Well, it can lead to hypokalemia, but in the same time, it is exacerbated function with hyperkalemia. So exacerbation of function is in the hyperkalemia. When you have hyperkalemia due to digoxin, that means that your prognosis is bad. But if you have hypokalemia, well, it's a side effect, but it does not mean that your prognosis is bad. A drug that displaces digoxin from tissue binding sites and decrease the clearance include the following. So basically, in different words, do not give these drugs with digoxin because they displace it from the tissue and make him, basically released in the circulation, which make him more toxic, including veramabile, which is a calcium channel blocker, amiodarone, which is a class 3 anti-arrhythmic drugs, and quinidine, which is basically an anti-malarial drug. You are like, okay, I can understand this, but why the hell anti-malarial drug is here? So, yep, exactly. So why quinidine is not a good idea? Why quinidine is a really bad idea? Well, regardless of the fact that how bad it is by disturbing the electrolyte and working at different channels, it has one more effect. Guys, see here, we have a drug, an anti-malarial called the quinine, and we have another drug called the quinidine. Are quinine and the quinidine similar to each other? In reality, yes. They come from the same family, but one of them is used as an anti-malarial drug, which is the quinine, and the quinidine is used as an anti-arrhythmic drug. Totally different function, but they are from the same family. Okay, so they write here the antidote for this. You slowly have to normalize the potassium, cardiac pacer, and anti-digoxin Fab fragments. And the most important thing is to give magnesium, because always when you have electrolyte disturbances, the first drug to give is magnesium. So now let's speak about the anti-arrhythmic drugs. Anti-arrhythmic drugs, you must know first of all that you have typical cardiomyocyte and atypical cardiomyocyte. So notice this for me, guys. If we speak about a drug, antiarrhythmic, a class 1, A, B, C, all of them work at typical or the atypical cardiomyocyte. Tell me, please. You can see, yes, it's in the typical one. See, you can see this phase. The phase 0, it's straight, which means it's typical cardiomyocyte. Typical cardiomyocyte. Okay, if I speak about drug class 2, which is the beta blocker, is it typical or atypical cardiomyocyte? Atypical, yeah, you can see the slope here, phase 4, the slope. Okay, next drug, I'm speaking about a class 3, is it typical or atypical? Typical, yeah, because you can see the straight line here. Lastly, last one, calcium channel blocker, typical, atypical? Atypical, yeah, because you can see the slope here. So basically the class 2 and the class 4 are atypical. The other ones are typical. Good. So okay, we can memorize that. Nice. So what else? Well, the antiarrhythmic sodium channel blocker. So they slow or block decreased conduction, especially in debularized cells. Well, debularized cells, which cells are debularized? Well, dead cells. Why would I give a drug for a dead cell? For ischemia. Well, in ischemia, your cells are 100% debularized. And thus, you would like to use a sodium channel blocker because it can function on them. They decrease the slope of phase 0 debularization. Are a state-dependent selective depressed tissue that is frequently debularized in case of tachycardia, especially post-infarction tachycardia. So, take a look here, guys. First of all, you can see here, like the slope 0 is kind of messed up. It's like this. It should not be like this. Also, you notice that the refractory period is much more longer, which it's good actually because it can prevent the ectopic foci from shooting here. If you remember when we spoke about like QT prolongation and ectopic foci firing, the problem with this guy, look what is he prolonging. See what is he prolonging? This area. What was this area, guys? This area here, what is it? How do we call it? Which phase? After the plateau, it goes down. What do we call the area after the... No, not... Rebularization. Yeah, rebularization. Rapid rebularization. At the rapid rebularization, when I make it longer, it's basically making longer QT interval. Yeah? So that's why we say, and why it's making it longer? Because of the potassium channel inhibition. You are like, no, wait a sec. You are messing up. This guy is too cool. He does not lead to function on the potassium channels. Well, he does. Okay? That's why we have a QT prolongation. So the class 1A only, be careful, they are different from each other. Class 1A, including quinidine, brokinamide, and disopyramidine. The queen proclaims disopyramids. Okay. So, mechanism, they have moderate sodium channel blockage. The moderate sodium channel blockage led to the difference in the phase 0. Yes, because at the phase 0 we had sodium entry. So the change happened at the phase 0. Also, increase action potential duration. Look how long it becomes. Like normally it used to be at this gray line from here to here done, but now it's like whoop, that's much longer. More refractory period, here it is. In the ventricular action potential. More QT interval, we just spoke about it, and it was why? Because of the blockage of which channel? Why we had a prolonged QT, guys? Which channel was blocked leading to the prolonged QT? The potassium channel. Excellent, you must know this. So some potassium channel blocking effect leading to a prolonged QT. Is a prolonged QT bad? Of course. Which side effect it can lead to? Torsade, yeah. So you can see here they write, it's the clinical use, it can be used for both atrial and ventricular arrhythmias. How can I differentiate between an atrial and ventricular arrhythmias? Which area of the ECG I look at? QRS complex. And if it was wide, it's ventricular. If it was narrow, it is atrial. Okay. Wide, it's more than 3 small boxes. Narrow is less than 3 small boxes. One small box is 40 milliseconds. Okay. You can see here some potassium channel blocking effect, both atria and ventricular, especially re-entrant or anectopic supraventricular tachycardia and ventricular tachycardia. Because you are making the slope of the phase 0 much more deviated like this, what will happen to the heart rate, guys? Yeah, okay, good. So, the adverse effect you must know about. Synchronism. Synchronism, it's the exact thing why I was telling you about, but it could be used for treatment of doctor. Exactly. So I told you it was the weird thing. It is one of the weird situations we have in cardiology, in which a drug that can cause it, we use it for the treatment. The same deal, similar situation we will face in GIT. If you remember, like Clostridium difficile can be treated with oral vancomycin, but oral vancomycin can lead to Clostridium difficile. Yeah, medicine is like this. Sometimes there is like weird stuff, but you must know it. So yeah, brokinamide can be used for wait a second. Something messed up here. I just want to make sure. I know that we use magnesium for sure, for Torsades de Bois. And brokinamide can be used for sure for WBW. Wait a second, let me see. I mean, okay, no, man, I think we are mistaken. No, it's a brokinamide. It's not. It's used for WBW, not the Torsades de Bois. Wolff-Parkinson-White syndrome and should be treated with rhythm. Okay, yeah, that's Wolff-Parkinson-White, not this one. Anyway, okay, so let's just speak about this. Okay, so the potassium channel blocking effect led to the Q2 prolongation. Synchronism you can also appreciate in which problem? It can you can see it in the antimalarial drug quinine as well, the exact same one. Synchronism is a side effect in which the patient has headache, but the most important thing is the tinnitus, which is ringing ears. Also, one drug toxicity that you must know about leading to ringing ears is aspirin. So reversible lupus-like symptoms. Wait a second. We saw this one before. Which other drug led to lupus-like syndrome? Hydralazine. Excellent. So far we have 2 drugs. There is one more to go. So heart failure also can be seen in case of disopyramide. So thrombocytopenia as well can be seen. Torsades de Bois. Why? Because of the QT prolongation. Then class 1B, notice the gray is normal and the blue is with the drug. So guys, notice here, the QT is actually decreased. It's not prolonged, it's decreased here. Yes, because it's shifting from here to here. So it has a weak sodium channels blockage, and the AB action potential duration is much lower. It preferentially affects the ischemic or depolarized Purkinje and ventricular tissue. So it seems like an excellent drug for preventing arrhythmia after an MI. Okay? So phenytoin can also fall into category 1B. Notice here, guys, they mention lidocaine and mexilatine. What is the difference between the two? The only difference actually that mixilotine is oral while lidocaine is IV. That's it. So, or muscular, sorry, not IV. Don't give it IV, guys. You know that like at the vet shop, they have this the vet when he, for example, wanna put a cat off and basically just give her the injection to kill it. You know what exactly the drug they give to the cat or to the dog or whatever? It's lidocaine. They give him a huge amount of lidocaine that stops the cat heart, basically. That's how they kill it. Really interesting. I did not know that. So, the clinical use, but they give it IV. That's why it kill it. Exactly. No, don't give lidocaine IV, please, man. I said that's how you kill the cat. You give it IM. Come on, don't give lidocaine IV. So, the mixilotine is the oral form of lidocaine. Okay. So the clinical use: acute ventricular arrhythmia, especially post-MI, digitalis-induced arrhythmias as well. I said that in the vet shop, one of the ways they kill cats or animals is by giving them IV lidocaine. Oh, so in humans, we mostly give it IM, okay? We like to give it IM because it's difficult to monitor it IV. Some rare times we can give it IV. The difference between these two types, the mixilotine and the lidocaine: mixilotine is oral, lidocaine is given like as a solution, you know? So it can be given like muscular, intramuscular. Adverse effects: CNS stimulation or depression and cardiovascular depression. You can see how narrow it makes the typical cardiomyocyte action potential. So the class 1C, flecainamide, propafenone, it goes something like this. So these two drugs are what? Sodium channel blocker, but they work really strongly at it. Notice here, guys, if you look at this, will they lead to any change in the QT interval? No change in the QT interval, straight. So strong sodium channel blockers significantly prolong the ARB, which is the refractory period basically, and in the AV node, and accessory bypass tract. Well, what is the accessory bypass tract? Can someone give me an example on that? Good. So no effect on the ERB in case of Purkinje and Wernicke tissue. So it mainly acts in the atria, not the ventricles. Okay, it acts on the atria. If it acts only on the atria, will it lead to inhibition of a? Will we mostly use it? Think about it. Will we mostly use it for, let's say, atrial fibrillation or ventricular fibrillation? AFib, exactly. So clinical use: supraventricular tachycardia, including AFib. We only use it as a last resort when nothing else works and we are just like giving up on this patient. We can try it for refractory ventricular tachycardia. Okay, the adverse effect. As adverse effect include, first of all, it could be pro-arrhythmic. Why? Because see, this is slope. You can have another contraction during this slope. So also it can have what? It has one more serious thing. It has contraindication in patients who have ischemia in their heart. So yes, but what I mean by this, if a patient previously had a like an ECG and you took a look at it and he had a Q wave, will you give him this drug? Contraindicated, exactly. Be careful about this one. Do not give class 1C for a patient with a Q wave. Okay? He will die. Okay, good. So now the class 2, beta blockers: metoprolol, propranolol, ismalol, atenolol, timolol, and carvedilol. The mechanism: they just decrease the vagus activity. and thus they lead to decrease in, sorry, not vagus, what I'm saying, beta blocker is sympathetic. Okay, so they decrease the SA and the AV nodal activity by decreasing cyclic A and B. Guys, if cyclic A and B is decreased, what will increase? Remember where cyclic A and B came from. Cyclic A and B, yes, ATP will be increased because, like we said, that beta 1, it leads to activation of GS, which lead to activation of adenylate cyclase, which convert ATP into cyclic A and B. So if you have beta blocker, you have less GS, you have less adenylate cyclase, more ATP, less CAMP. So you can see here less CAMP and less calcium current. Less calcium current, less contraction. Suppresses abnormal base makeup by decreasing the slope of phase 4. If you decrease the phase 4 like slope, you will have tachy or bradycardia. A brady. So finally now it makes sense why I used to explain you that previous material. So now you can take a look here and see the following. AV node particularly is sensitive to it. So the patient will have an increase in the BR interval, and if you speak about a drug called Usmle, it's really interesting because it will have very short acting. Guys, when we spoke about increase in the BR interval, which pathology we spoke about? AV blocks, yeah. So here's the thing. The beta blockers, when you give a lot of them, they are practically blocking the AV node, yeah? So they prolong the BR interval, which is the period between atrial and ventricular contraction. So what is the clinical use of this drug? Again, SVTs, ventricular rate control for AFib and atrial flutter. Remember the rate control. Rhythm control with amiodarone or cardioversion. So adverse effect, impotence. So I told you to be careful about this patient who has like erectile dysfunction. He has morning dominance, which means like erections, means psychological. If he does not, so probably, what is SVT? Supraventricular tachycardia. Impotence, basically, if he has the erection, he does not have the erection in the morning, and yeah, basically you start thinking about other causes, like for example beta blockers, metformin sometimes. So impotence, exacerbation of COPD and asthma. Cardiovascular effect include bradycardia, AV blocks, and heart failure. Okay, so we do not use it in asthma. Which drug can we use instead of it in asthma and COPD? Tell me please, guys. SVT means supraventricular tachycardia. We said that. Yeah, so it's calcium channel block. Calcium channel blocker, yeah. Okay, calcium channel blocker we use, yes. Cardiovascular effect lead to bradycardia, AV block, and heart failure. Okay. CNS effect, sedation, and sleep alteration. May mask the signs of hypoglycemia. That's why we need to be careful when we give it to a diabetic patient. When you give a diabetic patient a beta blocker, you want it to be selective or non-selective? Selective, because you don't want to hide the hypoglycemia symptoms and then the patient will get in a coma without even feeling the symptoms. So, metoprolol, is it selective or non-selective metoprolol? Let's see. Okay. Can lead to mild dyslipidemia. Propranolol, is it selective or not selective, guys? Okay, nice. You know the only one. Nice. So remember, from the letter A until the letter M alphabetically, it is selective. From letter N until letter Z, it's non-selective. Okay, non-selective. Okay. So propranolol can exacerbate the vasospasm in vasospastic angina. Beta blockers, except for non-selective alpha and beta antagonists, carvedilol and labetalol. Remember that labetalol and carvedilol, these are different. These work both at the alpha and the beta. They can lead to cause unopposed alpha-1 agonism if given alone for pheochromocytoma or for cocaine toxicity. Oh yeah, let me explain this. Guys, we have 4 receptors. Cocaine stimulates all, correct? So cocaine lead to more catecholamines, which stimulate all of the 4 receptors. Let's say that we give like a drug that inhibits both beta 1 and beta 2. Is that a good idea? But really bad idea. Why? Because instead of activating these, it cannot. So all of these catecholamines are going to activate these. When you activate the alpha 1, what happens to you? Not cardiac contraction, but vasoconstriction. Exactly. So exacerbated hypertension that can kill you. So treatment of beta blockers include saline, atropine, and glucagon. Okay, so one more thing I want to add here. Include the following. Take a look here. So you can see the slope of phase 4 has decreased significantly. Like it was like this, now it's like longer, which means there is bradycardia, prolonged repolarization at the AV node. So you can see, and then even at the contraction, it's much lower slope. Okay, good. Let's speak about AIDS. So this is class 3. It's potassium channel blocker. So they work at this area. So what do you suspect the patient to have a complication? Tell me, please. If it's working at this area, at the phase where is the potassium channels located? Long QT. Yeah, long QT. Okay, so the antiarrhythmic include amiodarone, butylide, diphenylide, and sutalol. Sutalol, you are like, wait a second, you are a beta blocker. What are you doing here? Well, yeah, it is a beta blocker, but it also has a potassium blocking effect. So they put it under this category. So the mechanism that they increase the action potential duration, increasing the refractory period, and increasing the QT interval. What is gay BB? That's weird. Okay. So clinical use include atrial fibrillation, atrial flutter, and ventricular tachycardia, especially with amiodarone and sutalol. Okay, so amiodarone, it's an amazing drug. Not because of the drug, but because of its side effects. Man, look here. You have a whole list of side effects. So let's tell you about these and then ask you if we use it or not. So sutalol is used, sutalol side effects include torsades de bois because of the prolongation of the QT interval and excessive beta blocker. So beta blockers prolonged what? The BR interval. So if they ask you exactly about sutalol, please remember, it's a beta blocker. So BR interval will be prolonged. Also, it is a potassium channel blocker. So the QT interval is prolonged. So sutalol is the only drug that prolong the BR interval and the QT interval at the same time. While if we speak about a drug called butylide, well, it's like any other potassium channel blocker, it prolongs the QT interval. Okay, now the amiodarone. I love this drug. It can lead to pulmonary fibrosis. Pulmonary fibrosis will lead to restrictive lung disease, and you can see it here in the chest CT and how damages the lung with all of this fibrotic tissue. Okay, so pulmonary fibrosis is hepatotoxic, lead to hypo or hyperthyroidism. Why? Because amiodarone itself, like the chemical formula of it, it contains what? It contains a lot of iodine molecule, okay? And thus it can lead to hypo or hyperthyroidism. Notice here, guys, if you take a look at this chemical formula, if you don't know about this structure, it's okay. Just you can see here an I and you can see here another I. These are basically iodine, okay? So when you have too much iodine going to the thyroid be like, well, I don't want to play with that. You can get hypothyroidism, and vice versa. You can consume it. So it also acts as a hapten, which can lead to corneal deposits. So let me, gray man syndrome. It can lead to blue or gray man syndrome. Look at this poor man. He's blue or gray, whatever you want to call it. It's after starting imidazole, yeah? So you see it has so many side effects. Look. Yep. So it acts as a hapten. It can lead to corneal deposits, blue-gray skin deposits resulting in photodermatitis. So it sucks, photodermatitis. Neurological effect, constipation, cardiovascular effect, like a bradycardia, heart block, and heart failure. A lot of side effects. Well, let's make it even worse. Oh yeah, they keep asking you about these guys. What is a hapten, guys? A hapten what is the difference between a hapten and an antigen? That's really important to be able to differentiate between a hapten and an antigen. An antigen is totally a foreign particle that is like foreign from your body, that the moment it enters inside of your body, what happens to it? An immune response is created. Well, a hapten is just a smaller protein, okay? And the hapten can enter your body and it does not lead to any problem. But the moment it attaches to a bigger protein, your immune system will recognize it as foreigner and will be like, toot, kill it. So a hapten is basically an antigen waiting to happen, you know? It's not an antigen yet, but when it attaches to its carrier proteins, it can become an actual, what? An actual antigen. So I just sent you a photo. You can check it on Telegram, please. Yeah. So the next thing is to remember the following. So you need to check the BFTs, which is the pulmonary function test. Why? Pulmonary fibrosis, you want to check it's not happening. LFTs, liver function test. Why? Because of the hepatotoxicity. Thyroid function test. Why? Because of the hypo and hyperthyroidism. When using amiodarone. Amiodarone is a lipophilic and has a class 1, 2, 3, and 4 effect. What does that mean? Well, we spoke about class 1 antiarrhythmic, class 2 antiarrhythmic, class 3 antiarrhythmic, and we'll speak about class 4. Amiodarone can work in all phases. Well, but what does that mean? It means it can treat any form of arrhythmias. That's what it means. So, now let me ask you this. With all of these side effects, do we use this drug? Do you think we use, yeah, a lot. We use it really a lot. Why? Because it can literally act in every single phase. I mean, if you have no idea which form of arrhythmia the patient has and give him amiodarone, it will work. So, yeah, but initially, most of the time, you might start the patient with amiodarone, okay? But you need to make sure which form of arrhythmia he has, and then narrow down the drug until you reach like a drug with the least amount of side effects. Okay, the last page of cardiology. Let's finish up. Let's do it. Anti-arrhythmics, calcium channel blocker, class 4. So these are the non-diphenhydramine calcium channel blocker, like diltiazem and veramabile. The mechanism, they decrease conduction velocity, and if they decrease the conduction velocity, you can imagine you will have a brady or tachycardia. Bradycardia, correct. So they increase the refractory period and more BR interval. So they can be utilized to prevent nodal arrhythmias, like SVTs. Rate control in case of atrial fibrillation, especially if the patient was asthmatic and you really don't want to use what? Beta blockers. So the side effects, they love to ask you about the constipation. I think the man who wrote this book had really bad constipation, and that's why they keep asking about it. They keep asking about constipation. I don't know why. So constipation, flushing, edema. And it can lead to cardiovascular effects, like, well, we just said it leads to BR interval prolongation, yeah? So if that is true, it's kind of like an AV block, yeah? BR prolongation, it's an AV block. So heart failure, AV block, and sinus nodal depression can occur. Notice here, you can see the phase 4 slope is going down. And you also can notice, oh, by the way, guys, before I forgot to mention for you one thing the other day, but it's a must. I even put a question on it, like on the group, so you will get it and you will not make the mistake. Okay, guys, see the funny current here? It has sodium, potassium. Please write here plus calcium channel effect, okay? That's it. I can now feel peace and sleep. Okay, so it makes sense. There is a slow raise in the action potential because of the decreased slope. Prolonged repolarization at the AV block. Why? Because of the blockage of the, because of the increased refractory period. Excellent. And you have much slower rate. So for an AFib, this seems like amazing. Rate control stuff. Okay, now the other drugs that are not classified. The first one is adenosine. It just takes the potassium outside of your cells, and if your potassium is going outside of your cells, you will have hyperpolarization of the cell itself. Okay, so, and there will be less calcium entering, less calcium influx into the cell. So less calcium into the cells, that will lead to less contraction. Okay, there also will be a decreased AV node conduction. Before I continue, guys, is adenosine quick acting or short acting? Is it long acting or short acting? It's ridiculously short acting, guys. It just acts for seconds. A drug of choice for diagnosing or terminating certain forms of SVTs. So, let me give you the following question. If you get a 25-year-old lady who comes to you and she has her step 1 exam tomorrow, and she is really stressed, she's shaking, you check her heart rhythm and you notice that she has supraventricular tachycardia, and you do carotid massage on her and it's not functional, it's not working. Which of the following drug you will give her? Is it 1, adenosine, 2, diazepam, 3, beta blocker? Guys, that's a tricky question. In acute anxiety attack, the supraventricular tachycardia is because of the anxiety, that's it. So you give diazepam. You do not give any other drug that affects on the heart. You need to play with the brain, not the heart. The problem is in the brain, not in the heart. Okay? So the correct answer is diazepam. Good. So it's a common tricky question, actually. I'm not kidding. You might face it in your world, actually. So very short acting, they write. So the effect is blunted by theophylline. Guys, theophylline and coffee, both of these guys are adenosine receptor antagonists. That's why they help you stay up. Remember, theophylline was used to be, they used to use it for asthma, not anymore. And it's a really interesting drug, really useful, but the side effects are horrible. It's cardiotoxic in a really serious matter, so that's why we don't like to use it anymore. But overall, theophylline and coffee are from the family of a drug called, just a second, methylxanthines drugs. And this family is just like they block the adenosine, okay? The most cheap drug. They are highly effective, but the adverse effect of them is just horrible. So adverse effect of adenosine include flushing, hypotension, chest pain, and sense of impending doom. What does it mean? The patient have this supraventricular tachycardia. The moment you push the adenosine inside of him, he'll be like, "Doctor, you killed me," and he will feel like he's dying. He will feel it. He will actually feel like he is dying, and then everything will be okay. So yeah, don't get too scared. And also they can have a bronchospasm. So, but how long? 15 seconds, that's it. Okay? So yeah, you give him that injection, close your ears and wait for it to finish. Yeah, and it burns its veins, which is horrible. And what makes it worse that you be like, okay, it burns its veins, let's put it in a central line. Well, he's in really acute stage. He will not handle a central line now. You have to push it inside of his veins right away. So, magnesium, it's effective in torsade de bois and digoxin toxicity. Look, if the patient has an SVT not due to anxiety, like he just had an SVT due to a secret ectopic foci inside of his heart, okay? It's like the adenosine, when you give it to the patient, it's like slapping the heart, okay? You give it as a one impulse, that's it, like one injection, and it's like giving a slap to the heart and telling him, man, function normally, don't do this, bad boy, okay? So it just slaps the heart and put him back into normal rhythm. Exactly, it's like bitch slap him. Okay, so the last thing here is ivabradine. Oh my god, I really did not expect to make a joke about the Nazis. But this is Eva Braun. For you guys not knowing anything about history, Eva Braun is the lady that Hitler used to date, and he married her one night before he killed himself. Her name is Eva Braun or Eva Bradin. Okay? So Eva Braun don't like funny channels. She likes the light in the end of the tunnel. I know. So ivabradine prolongs the slow depolarizing phase 4, which is what? By selectively inhibiting what? The funny sodium channels. So Eva Braun does not like funny channels. So she blocks the funny channels. That's her function. So what is the function of this drug? It's used for chronic stable angina in patients who cannot take beta blockers. Who cannot take beta blockers? Well, someone who's asthmatic. Someone who has what? Someone who has like this, except asthma, there is one more thing, bradycardia as well. You cannot give him beta blocker. It can be used in chronic heart failure with reduced ejection fraction. The most important thing about this drug is its side effect. They can ask you about this luminance phenomena. What does it mean? They start to see flashes of light, guys, okay? Visual brightness, hypertension, and bradycardia. Thus, I wrote, she likes the light in the end of the tunnel because she killed herself. I'm kidding. So, Eva Braun don't like funny channels, so it inhibits funny channels. She likes the light in the end of the tunnels, so she has this luminous phenomena in which they have bright flashes of light in front of flashing in front of their faces. And that's it for cardiology. That was a long section. Whew, that felt good. Okay, so let's just take a quick look at one more thing, and I will let you go, guys. Pharmacology is important at the exam, but the most important subject in the whole book is pathology. It makes around 60% of the exam, so don't joke with pathology, man. The most important subject. Okay, so for today, pharmacology of cardio, we are done with this. Tomorrow will be mainly neoplasia, and we will review some cardiology, like we'll just take a look at it, see what's up, what's there, what's not there, stuff like this. What you guys, if you have any questions, please accumulate them. Like if you have questions from you or stuff like that, send me tomorrow during the day, and we can discuss them at the class, okay? If you have time, yeah, do it, of course. Also, please notice here